growth rate of obesity from 2016 to 2020 was 114 million patients. That's 2/3 of population of Russia that could suffer from obesity for the last 4 years. And speaking about the combating with obesity, we are definitely losing. Well, what to eat in order to lose weight? You always heard this phrase from your patients, maybe even your colleagues. Some people have jokes, but each joke has some piece of truth. Any specialist can tell you that in order to reduce weight, you need to do two things. You lose more energy than you gain. So that means move more and eat less. It's all very simple. But why? Still, we are losing this fight with obesity. Why? It's all very simple. Because unfortunately, our patients, they are not in vacuum. They live in society, in socium. Let's look which factors influence them and influence their failure to combat their lifestyle. Well, first of all, availability of food. Definitely patients may have very different incomes. Well, some patients can go to Michelin restaurants, so maybe they have their private chefs, but others can afford very simple and very cheap products, food, waters, grains, potatoes, so mainly carbohydrates. Some people have genetic predisposition to obesity, and then patients have different baseline level of metabolism. Some people stay for 3 hours in gyms, and some people walk. And most important are psychological factors. These are food disorders or depression in our patient that could be missed and misdiagnosed. And if you refer to any guidelines for weight reduction, they look quite complete, but why? Our recommendations are not working properly because patients could come at very different stages to preparedness to change their lifestyle. There is a stage of just observant. They're not ready to talk about changing of lifestyle, and all your recommendations, even medical indications, would not be followed. And only starting from the stage of preparation, when the patient starts off thinking how to change their lifestyle, then all recommendations that could be given, they will be implemented, and patients will come to you not only with a lost weight, but the words of gratitude. Any link between obesity and depression? Let's start from the oldest one, which is 2010, and this is systematic review and meta-analysis that included 15 studies and 55,000 patients with obesity and 7,000 patients with depression. So we tried to look at the dependence, whether depression could be predictor of obesity or not. But this is the bilateral road. As you can appreciate, patients with obesity, they have risk of depression, which is higher than in general population by 55%. But in patients with depression, the risk is 58% higher. And there is clear link between depression and obesity. And this link between depression and overweight is not shown. Are there any genetic aspects we should think of and talk about? The well-studied gene is FTO gene, and meta-analysis of 2017 included two groups of patients, about 7,000 patients with depression and the same amount in the control group. You can appreciate here the significant level of polymorphin gene FTO depression and BMI was reported, and depression increases FTO influence towards BMI. Let's move on. Is it all obvious? Here on the left, we see the data of another study. This is another systematic review and meta-analysis dated 2016. Here we have 226 patients recruited, 23% were males. And I have to say, according to gender, we don't see any risks of depression with obesity, but it was quite convincing data showing about depression and obesity, but not opposite. And that's another study here on the right that tells us, no, it is obesity predictor of depression, but not depression the predictor of obesity, not the opposite. Why? It's quite contradictory. It may seem quite clear why some data, and probably most scientifically based approach, systematic review and meta-analysis, evidence level A1A, and we see totally different results in the other study, because our patients could have very different type of depression. It could be atypical and melancholic, and later on I will speak about it more. Weight gain could be adverse event of antidepressants that our patients are treated with. And patients with depressions, they normally have lower physical activity, could be prone to the more food intake, and mainly it refers to the atypical depression, because melancholic one would facilitate weight reduction, because patients have no interest to eat. They normally have lost appetite. And that's the reason why in systematic reviews we see very contradictory results, depending on what type of depression was prevailing in this or that patient group. In some patients, it could be weight gain. In others, definitely not. So that's the pathological link between depression and obesity. Have you ever looked at depression from the angle of inflammation? But in fact, this is chronic inflammation. What we see is increased level of pro-inflammatory cytokines, TNF, interleukins, C-reactive protein, and all they are reduced when depression is resolved or when it goes to remission. Appreciate this vicious circle. This is generalized data. Obesity leads to the changes of hypothalamus, thyroid, adrenal axis, and we have emotional dysregulation that could launch the depression, and totally opposite, metabolic disorder due to the deterioration of that axis may lead to the development of obesity. In its turn, when I was preparing my presentation here about Cushing syndrome, and it looks like totally different topics, Cushing, depression, obesity, but in between we see lots of things in common. And specifically, this is hypothalamic pituitary adrenal axis. So let's try to answer key questions: whether the presence of depressive disorder could influence the progression and outcomes of obesity. Yes, the treatment of obesity improves and depression improves. Reaction to antidepressants, could it influence the patients with depressive disorders? And that's an interesting question. And yes, this link is available between the poor response to treatment or very slow effect, especially it refers to tricyclic antidepressants, and to less extent to the serotonin reuptake inhibitors. How depression influences obesity and vice versa. BMI reduction correlates with the severity of depression. In patients losing weight, there was improvement of depressive symptoms and reduction of antidepressants, and the data of these studies are available. And the last but not least, whether medical treatment of depressive disorders influence the obesity outcomes. So this is adverse effect of antidepressants. Some of them, yes, they influence, some not. Tricyclic and also irreversible MAO inhibitors, they will facilitate increased weight, and modern drugs will be more neutral to the weight, and we have also ibuprofen that leads to weight reduction. So these are the responses to the key questions that could be given. Do we have to refer our patients with obesity to psychiatrists or psychotherapists? Well, I will not give you my proper answer. We have interdisciplinary clinical guidelines for the treatment of obesity and comorbidities published in 2021. It said that all patients with obesity, excepting secondary reasons of increased weight, the consultation of psychiatrist or psychotherapist is indicated, and the level of evidence is pretty high. So don't miss depression. Please refer patients. Don't be shy. Refer them to our colleagues, psychiatrists and psychotherapists. Thank you very much for your attention, and hope seeing you in other sessions, and I will be happy to answer your questions, and I give the floor back to Alexander. Grigory, thank you very much for fantastically interesting presentation. You unleashed the challenge, the main challenge, and there is a positive logic, in fact, that you spoke first, because you raised the problem of depression, and we know very well that later on we'll speak about geriatric patients, patients with CHF, which very frequently, these are already patients who are overweight. So it's quite logical that now psychiatrists with big expertise in internal diseases, Anastasia, will make the presentation and will speak about very important steps, useful steps to diagnose depression. Microphone is yours, Anastasia. Thank you very much, Alexander. Thank you very much. Good afternoon, dear colleagues. And now I go right to my presentation. In my routine practice, each therapist, each cardiologist is using such routine methods of screening like measuring blood glucose, measuring of blood pressure, and we speak about a lot in our events. You know how important these screening procedures are. And today I'm offering you another tool how to save lives. And let's discuss why is it so important for our patients. I will give you terrible statistics. About 700,000 people in the world take decisions to commit suicide annually. This is a tragedy that influenced not only one life, but also relevant to the families and relatives. And in the studies, we see triple growth among children who died because of suicide. And according to the studies, each fourth patient in the outpatient management faces this or that type of depression. About 80% of the patients, 80, that for 3 months before suicidal attempts refer to the medical care. So it's not always psychiatrists, and it could be doctor or cardiologist. So we should know how to see that. So very frequently we see that in patients after hospitalizations, those who are in specialized institutions, let's say in the orphanages, in the care homes, also severe chronic diseases. It's obesity, ischemic heart disease, Parkinson disease, different types of dementia. And in my presentation, I would like to remind you about a very special group of patients, young females, first year postpartum. Up to 20% of them face postpartum depression. And we have to be very focused on them. And very important, how to split in between depression, which is independent disease, like recurrent depression, when this depression with other psychiatric disorders that work for psychiatrists, and when it's a symptom of different somatic diseases. So that means the role of therapists, cardiologists, neurologists is very important. So we have to rupture this vicious circle and to identify symptoms properly. And although symptoms of depression are quite widespread in the clinical practice, not many patients are discussing these symptoms with their treating doctors. And let's see what you already see in your work. Which symptoms are the most prevalent? Here you see so-called risk factors. This is American Association of Psychiatrists that presented that. So we say that 2/3 of the patients headaches, chest ache, like stone on the heart, psychological pain. So you make the study and you see nothing. It could be the other picture, anxiety with different somatic symptoms, like a peace in the throat, suffocation, different ups and downs of rhythms, numbing, nursing, and hot flushes. American Association of Psychiatrists identifies the symptom of irritable bowel. So with the stress, with worsening of the psychiatry situation, diarrhea, flatulence, and we don't see the reasons. And we send to psychiatrists. So they have lack power, the sleep could be disordered, appetite could be disordered, physiological problems that patients come to the therapist. The red flags could be refusal from recommended treatment when they're non-compliant or they don't take at all. And when patients come very frequently, let's say more than 5 times a year without clear reasons, so that's a red flag. Please check for depression. What we see when we start asking questions, first 2 criteria of depression, this is depressive mood and no interest to the activities. So here I also show you the timing criteria, 2 weeks or longer that should symptom take place. They complain to apathy, being lazy. Please clarify what this laziness could mean. They could complain to the desire to do something, no desire, some negative emotions, and they don't want to resolve issues, to procrastination, excessive guilt, negligible thoughts. And don't be afraid with their thoughts of committing suicide. Patients speak very rarely about it, but if you ask, they actively and honestly share about it. And please, don't be afraid. It's myth if you cause them if they don't have it. If they don't have it, they don't have it. But if there's depressive symptoms plus suicidal thoughts, they will talk about it. It could be a very different rate of severity. Thoughts like, well, it's good to disappear, or maybe I have a car accident and it's all gone, up to very clear plan, This plan could be kept in chronic patients like plan B for the things. So first I will try something, and this is plan B. For example, I have 1 or 2 attempts of treatment, and if not, I always have plan B, which is committing suicide. Some patients, they believe these thoughts are normal, and all people, sooner or later, according to these positions, they think about it almost daily. When we start the treatment, patients are quite frequently surprised. Oh, maybe you don't think about that? How come? How come? Other symptoms, weight reduction, reducing of appetite or increasing appetite disorder, sleep disorder. It could be classical sleep disorder, like described in psychiatry books, when they wake up at 4 or 5 and feel bad, very bad, and they cannot sleep any longer. And also excessive somnolence, sleep disorder, some nightmares. So we have to pay attention to that. Among other symptoms, we see loose interest to sex and no normal reaction to the ordinary events. Also, there is another symptoms of depression is slow thinking, and maybe psychophysical slow thinking, slow thoughts, and person actually becomes very slow. And subjectively, for the doctor, when they over complain, so there is impression of severe symptoms. For example, if there is anxiety component, but when hepatic component is prevailing, and most important is psychophysical, so they're not almost complaining, but they're speaking fewer and fewer, and there is more active work of the doctor to identify the depression. I think it's important for all the patients. I want you to be suspicious about it. I want you keep this idea. So no complaints doesn't mean no depression. We have to be very active and very cautious about depressive symptoms. I want to demonstrate you this slide as depression by itself, by its nature, is quite heterogeneous situation. So number of authors consider depression as sort of a continuum where we see very different rate of severity, very different combinations of symptoms. Let me give you 2 examples. One of them is milder example, where a person still can work, but he or she could see that it's difficult to do. So it's not interesting to go to the bar, to talk to the family, quite fatigued. It looks like asthenia, but if you go deeper, then you can identify all these depressive criteria we spoke about before. And the second case, more severe, when the patient cannot manage what he or she is doing, stay late at bed, prefers loneliness, prone to cry, thoughts about death, terrible feeling of guilt and sleep disorder. That's another part of this continuous, another degree of severity of this depression. And here we come to the moment of screening. According to different studies, in the absence of screening, half of depressions could be identified, those people who are suffering with depressions. So it could be very different reasons here. Patients, they don't report due to different fears, stigmatization. So they are convinced that this is not the competence of GP, although any doctor could suspect any disease, but then refer patient to proper treatment. You should talk to patients about it. Patients may be afraid of antidepressants. There is a myth that they have dependence, and it is not so. And I would like to provide you some screening tools today. You can take a picture of this slide, which is quite useful, and you can go back to that in the recording. And for today, we'll talk about one tool only. Very fast, very effective, very convenient in the practice. First, we ask just 2 questions to the patients, just 2 questions. Have you ever felt in the recent weeks the feeling of hopelessness? And the second question, where they report reduced interest and pleasure from what they're doing for the last 2 weeks. If you give short answer like me, it could be scores. If you get 3 or more, or if you asked orally and at least one question is answered positively, then you refer the patient to further tests and to psychiatrists. If they resist, give the continuation. For example, first 2 questions are answered. There are 7 more. 7 more questions. Each of the questions reflects particular criteria of depression, because this is very simple. He or she puts a tick, you calculate the score if it's 10 or more. So that's direct indication to refer to psychiatrist. You can use the results of this screening like an argument to refer to psychiatrist. And if patient tells yes to question 9, question about suicide, then this is also an indication, regardless of other answers, direct indication for additional study and diagnosis in the specialists. So there is additional question 10, you see here. It's not included into the scale, but again, it reflects the rate of influence to the life rate of dysfunctionality in the different orders. Any screening tests, and I repeat once again, could become particular bridge, the beginning of talk about possible psychiatric problems and referral to the specialized care. With that, I thank you very much for your attention, and my colleagues will continue this very interesting and very important topic. I'm happy to invite you to be interactive. Please give your questions in the chat. Please submit to the social networking of our associations, and we will be happy to answer all the questions later or now. Thank you very much. Thank you very much, Anastasia, for brilliant presentation. Very good expert position of practitioner, psychiatrist practitioner. And thank you very much for mentioning the opportunity to ask questions, because we know that we have very big audience, about 1,000 connections today, and we should clearly understand that definitely we will not be able to answer all the questions, but as usual, we take this commitment to answer them in our Telegram channel. So we will try to connect all the speakers, and main questions will be asked and definitely answered. And we move on according to our agenda. And it's a pity that in the framework of this symposium, we will never have enough time to speak about modern methods of treatment, but we now touch very serious cardiovascular pathology. We will speak about CHF, and also I'm happy to give the floor to our next expert, who is the medical doctor, PhD, and he's an expert in the heart failure and depression, heart failure and depression. Probably I'm running too much ahead. Maybe I'm simplifying the situation, but as far as I know, up to 60% of the patients with a high functional class with heart failure, they are in depression. But I think what is much better, much more expertise. And Natalia, the floor is yours. Yes, depression and CHF is a very relevant topic, because depression is 2-3 times more frequently in chronic heart failure. it's much more frequent versus other diseases. And today, this figure varies from 13 to 77%, according to different publications. So they say that patients with CHF could have depression from 13 to 70%. And in the hospitals, it has been confirmed that this is the data of national and international studies. They say that these figures are even much higher. And definitely here, we could see another fact. CHF as a disease is becoming elderly, and middle age is quite senile. That definitely could reduce emotional background for the patients and their capacity to tolerate burdens. But on the other hand, this is also general trend related to the increased depression rate in general. We see that very frequently, and it now takes one of the leading positions. Here we see very severe depressive disorder and disease. We listened to the previous presentation when we heard about obesity. We clarified this link, but here this link is already proved. And definitely there is influence of disease to the depression is already proved. These are very strong symptoms due to the pathological mechanisms. They're producing quite strong disorders, but on the other hand, it leads to the depression. But on the other hand, depression itself worsens the course of CHF and influences the outcomes of the disease and definitely influences the quality of life of our patients. Sometimes it's very difficult to verify the symptoms because actually symptoms are overlapped with the features of the disease itself: low energy, increased fatigue, increased weight, problems with attention, cognitive disorders, etc., etc. And also it has been proved previously that today depression is manifesting in CHF patients in very important spheres like emotional manifestation, physiological, cognitive manifestation, behavioral manifestation, and all these symptoms, they are quite well known to the doctor himself. And we would like to illustrate some of them also emotionally here. This is the desire, and they wake up early and they wait that something bad would happen. So also unpleasantness, no desire in life, reduced interest to the physiological manifestations, sleep disorder, appetite disorder, motoric disorder, gut and reduced sexual desire, energy tonus, etc., etc. This is no strong powers, and pain, and it could be somatic by its nature. And definitely these are also behavioral difficulties, and here we need to mention one of them, and avoiding contents, avoidance of the contact, and definitely it's passiveness. It's difficult to wake up from the bed, from the sofa, to do something, to start doing something, and also probably the most challenging and one of the brightest manifestations related to that. It's a problem that would be covered by the next speaker. And again, this is the same disorder, which is very clearly shown. Cognitive disorders, they lead to the fact that it's very difficult to remember all indications, it's difficult to follow them, and also the other manifestations of the depression. But on the other hand, these manifestations, they also influence the type of the disease as well. Atypical manifestations here of any type of depression is so-called depressive triad. which is most frequent feature that were already shown in 1960s, iron B. That's the cognitive approach in the treatment of depression that is dealt with the leading positions here. And it is emotional disorder, reduced mood, depression, and also slowing in thinking, passiveness, rigidity, etc., no initiative, and also all thoughts, they are around the same. And it's difficult for people to be concentrated on something else. And also complete stuff. Cognitive behavioral psychotherapy could play a very important role. This is British study, which is showing us this vicious circle of cognitive triad with its specificity, physical and cognitive, and also general activities. Here, I wanted to speak about reduced activities, self-assessment, mood, etc. And I would like to draw your attention to the fact that, unfortunately, in this situation, the productive attitude, which was typical for them when they were healthy, they are not working. They are not resolving the situation. That definitely leads to the absence of change for the better. And it's also manifesting, and it influences the compliance to treatment, creation of healthy lifestyle, and also general and social success of the people and desire of being. For the depression in cardiological diseases and specifically diseases in chronic heart failure, we can identify two leading types of depression, which is nosogenic depression related to the vascular component, reaction of the personality to the disease, and somnotogenic depression as a disorder which is caused by the disease itself. And definitely it happens only in severe forms of depression as the change is happening at already organic level and mainly related to very severe and higher rate of disease, which is chronic heart failure, especially the second and mainly the third functional class. And also we can mention that the structure of nosogenic depressions is different from the structure of somatogenic depressions in patients with CHF. For them, we see prevailing anxiety-based and hypochondriac symptom complexes, and most frequently it is related in patients with CHF first functional class. And the huge role here is the personal parameters and like pessimistic perception of life and death, some decompensation, non-motivated desire of fear of death and disability, so-called cardiological fears, heart failure, fear that my heart will be broken, and they're afraid of that, and definitely demoralization that is seen in the specific behavioral aspects. The structure of somatogenic depression is important, and it does not mean any hypochondriac anxieties, but mainly related to very severe aspects like fatigue, tiredness, depleteness, very difficult physical aspects that for patients, it's objectively very difficult to get up and go. And definitely we see deterioration, cognitive deterioration, the feeling of hopelessness and ignorance. From 4 to 7%, according to different studies, report comatogenic depression in patients with CHF, the one which is quite severe in terms of pathological feature, which is related to that comes from unknown origin related to the existential, so the desire, the apathy, loss of values, such features which are not demonstrated in other types of depressions or not seen very strongly, let's say. But here you clearly see how they survive through this existential crisis, and definitely it proves very strong influence. The specificity of depression is characterized by the fact that most frequently, and it is reported by the number of studies, it is seen in somatic complaints, and it's prevailing versus the patients without CHF. Feeling of guilt, angry, hopelessness. Number of patients, they are seen not so frequently, and there is a statistical difference shown here according to very big screening tool which was done and carried out quite recently. So this is data of 2008. So this is again British data, and here they speak about thematic and according to the complaints related to somatic situations, sleep disorder, appetite disorder, loss of energy, etc. So this is the selection of patients with CHF and without CHF. There was no big difference here. And negative influence of depression to the patients with CHF. It's related to the fact that depression influences the seeking of recommendation on healthy lifestyle. Sometimes it's difficult to do for the patients and difficult to control, then compliance to treatment. That natural fact, cognitive disorders and emotional background reduction when it's complete ignorant and you don't want it. So all that replaces therapy, and it's difficult for them to remember the scheme of treatment, the point of treatment itself. Definitely, they should make a decision about hospitalization, and also there is increased risk of death at the end. And our colleagues are showing some other scale, and they're showing this is very famous and very fast scale, which has just 7 points, scale of anxiety and depression, but where a doctor could give this questionnaire to the patient, and if we see 80 or more, then definitely it's quite tension, and we should think about possible depression here. And definitely we should set here clear link with the doctor psychiatrist in order to administer the treatments, antidepressants, and this stigmatization of psychiatry, which is very actively followed for many years, is slowly reducing, because now many people, they refer to get care. So this culture of referral to get care, and also sort of a myth that antidepressants are not easy things and it's difficult to get rid of them. So this myth is already lost, and the big role should be played by the relatives of these patients, and it's important in very different aspects. And from the position of the correction of depressive disorders, they should reach two objectives here. This is strategic objective to eliminate symptoms of depression, and if possible, or at least reduce these symptoms, and definitely use their own mechanisms of combating resources of the individuality. So main important objective here of psychocorrection related to the behavior, cognitive and behavior treatment, because it's played the biggest role for these patients, and its involvement of the patients into the action that leads to the pleasantness to them. So a big role here would belong to fantastic method of the cognitive behavioral psychotherapy, which is behavioral activization of activities, but not avoidance in difficult situations, in the normal life situations. And it gives them the skills of self-control, which is very important. The basic mechanisms here of psychotherapy. This is training, this is multiple repetition, step by step, bit by bit, day by day, with the follow of relatives. And here, what we see here is different type of CHF. So that's the first functional class. This is milder form and milder form of depression. And in CHF of functional class 2, 3, more severe form of depression. So these are different types of behavioral activation. So it's important to understand your own resource and to recover your resource and to do what is more pleasant. Together with such patient, we give a task for the search of the resource, and definitely together with the patient, we can discuss properly what patient can do for himself or herself now. So there are many different technologies here. For elderly patients, senile patients, for severe patients, it's very important to have actually timely schedule, which could be very helpful to avoid doing nothing, and also feeling of satisfaction, which is very important. A very important tool is actually support of these patients. And we understand that depression, it's really very severe, very difficult, complicated problem. Also some cards like shown here, because I'm good, I can manage, I will manage, and definitely we'll look at the type of the personality of the patient. What is very helpful is a token treatment. If you do something, put a tick, give a token, or maybe sort of a small reward or bright letter, let's say green or bright. If you fail, do something else. And patients, they are playing this game with tokens rather readily. And the most important here that we involve control here, and control could be very helpful for them to wake up from the sofa and make their own schedule. And also satisfaction is important, whether it worked from 5 or 10 points, then pleasure. With more preserved, better preserved patients, definitely we can make the list of achievements. And this is a fact. They come to visit us and we support it. You need to wake up, you need to dress, you need to get dressed, for example, to make a makeup. And let's say we can tell you, oh, yesterday you were wearing quite a nice decoration jewelry. Why don't you wear it today? So it activates them. And so please, that's very simple schedule of activities that will be very helpful them to follow them. And also important to remind relatives, they shouldn't support them in depression. They should guide them, guide their activities. It's important. To help them to be activated, to do everything to guide the patients. And for more preserved patients with CHF, what could be good is quite important technique. Working with automatic thoughts. Why? Why do I have this thought that I have no power, I have no energy? Why we have anxiety or hopelessness? Why? Why do we see that? Lack of action. And altogether, we can catch these negative thoughts and change them. So, what we need is active work, active behavioral activation, and search for resources in the patients is very important. At a very basic level, could be very helpful to manage depression, and also will help them at least to preserve healthy lifestyle. Thank you very much. Natalia, thank you very much. We are extremely grateful to our speakers that we are sticking to the timing, because we are receiving very many questions. And if we manage to keep up this pace, so hopefully at the end we will enjoy Q&A, answering questions. So let me go now directly to the next presentation. And this is our expert in gerontology, correspondent member of Russian Academy of Sciences, Professor Tatiana Petina. She will speak about the depression of geriatric patient. Microphone is yours. Please start. Dear Alexander, dear colleagues, a very good afternoon. The topic of geriatric patient depression is one of the very relevant and very big topics, and for such short period for presentation, definitely we cannot cover everything. But let me draw your attention to most important sensitive issues for the diagnosis and treatment of depression in the later age. In the mature age, we have to say that the prevalence of depression in geriatric population is very much varied. But according to the majority of studies, we see that the prevalence of depressive disorder in elderly groups is much higher than in younger age. Dear colleagues, I want to provide you the data of the study, and most probably you already saw this data 1 million times. This is COMPASS data, and you see that the risk of depression is increasing 1.2 times every 10 years. Why we see so many patients with depressions? Well, we could give you really many important factors, but let me draw your attention to two big groups. And I think they deserve your attention. And let me mention that there is no doubt that with time, the functioning of organism is changing. There is reduction of neurogenesis, cognitive process become more rigid, there is reduced tolerance to stress, and architectonics of sleeps is changed. Actually, aging, it's very special social burden to the organism, and we need to manage that. First of all, the age of losses and somatic diseases and somatic burden, number of comorbidities. That's another very big topic that I cannot dive deep now. This is also reduced social status, and this is loss of social status, and also the change of the stereotype of life, which allowed to support self-esteem at a proper level. And the previous speakers already mentioned that we need to remember that with time, the probability of suicide is increasing. There are many difficulties for the diagnosis of depression in the mature age persons. How can it be explained and what it is related to? If you look at the concept about depression, about the younger generation, then we will definitely see that there is at least some hypothesis. But if you look at the mature age elderly persons, well, there are many ideas, but there is no strong concept that will put together into the common understanding. So there are very many different clinical forms of depression. And if we look at, if we follow the recommendation of International Disease Classification version 10, and if we count definitive criteria, so they would not be sensitive enough to the available symptoms. And sometimes it is really very difficult to identify all the symptoms of the patients and put it into the frames of IDC version 10. Sometimes doctors believe that depression, especially in the elderly age, is quite expected, and there is nothing special in the current social situations. And there is a question, and what do you want in such life? Also, comorbidities and somatic pathologies are quite strong. On the other hand, we have to keep in mind that elderly people, frequently they don't want to admit the presence of psychiatry problems. They try to express it in different terms like painful sensations, and we have to remember that in elderly persons, the process of events processing is changed, and there is a trend to somatization of traumatizing events. And that's another and very interesting topic, why somehow people transfer emotional to the physical. In the previous presentation, we already spoke about cognitive disorders, and I would like to emphasize that mature age depressions very frequently associated with other types of disorders. And here on the slide, you can appreciate this trend. Almost half of the patients complained to the memory reduction. That is about concentration, decision-making, and pace of intellectual activities. And in 1/4 of the patients, they were confirmed cognitive deteriorations. And we have to keep in mind that cognitive reduction, that's an important factor for depression development as depression itself, because very frequently it's a risk factor. It's a risk factor for cognitive reduction as well. So this is Bennett Thomas data with co-authors published in 2014, showing us very clearly these figures. It's meta-analysis that included 18 studies, more than 10,000 patients, and it showed that risk of dementia development in patients with moderate cognitive disorders in the presence of depressive symptoms was increased 1.28 times. And also, patients with chronic depressions demonstrated high risks of dementia development, mainly Alzheimer type of dementia. Now, I want to say a few words about the treatment of psychiatrical disorders of elderly patients, because it seems to be quite important. Right now, the practice of milder depression, it could be treated only by psychiatrists, those who diagnose these patients. I think it's, and we administer specific treatments for drug. We also should remember that we should give priorities to monotherapy, and we have to assess the drug-drug interaction, which is important because number of patients, they already have cardiological treatments and neurological treatments and therapeutical treatments. It should be proper dose titration. And also, please don't forget to combine pharmacotherapy with non-drug methods, with psychotherapy, with cognitive trainings and physical exercise. And the biggest priority is to reach complete remission. What also we should remember when we administer treatment to elderly patients, antidepressant to elderly patients. In elderly patients, we see increased half-life period. They are very sensitive to the dosages of the drugs. There is a high probability for the development of side effects, and if it develops, then you need more time to resolve spontaneously. The initial dose of antidepressants should be 2-3 times low in elderly patients versus younger patients. And normally it's a chronic depression, and to treat such patients, it requires time, it takes longer. And there is a big dilemma here. On the one hand, these are elderly patients who need to be treated longer, but on the other hand, they should be treated the way to avoid side effects. And then the question is how to treat them, how to treat. Definitely, they should be treated with antidepressants. These are selective serotonin reuptake inhibitors, SSRIs, because they're quite effective and very popular. And also, dear colleagues, I would like to draw your attention to 2 drugs that you know and you use in your practice, which is fluvoxamine. And this treatment this is triple effect, as we all remember that in depression, the level of melatonin is reduced at night due to inhibition of metabolism and suppression of cytochrome in liver. Then melatonin in blood could be increased. As I said before, fluvoxamine works through SSRIs plus antidepressive effects, and also anxiety effect, which is very important for the treatment of elderly patients. Also, it has another important property. It's very strong agonist of sigma-1 receptors, high concentration in limbic. It is proved that sigma-1 receptors stimulate neurogenesis. This is multimodal antidepressant shown here. With increased level of serotonin and also increases level of glutamate, noradrenaline, acetylcholine, and histamine. Procognitive neurotransmitters facilitate the improvement cognitive functioning. And now, which specific cognitive functions could be increased? So this is the study under the lead of McIntyre. So it improves the attention, the speed of reaction, and memory better than placebo. And wrapping up my presentation, I would like to draw your attention to the lifestyle. Lifestyle is one of the key conditions that could influence the development of cognitive disorders in elderly patients with depression. And you can appreciate it here, quite fresh data of the British study that included almost 500,000 patients, where they reported that healthy lifestyle increased risk of depression development and also dementia after the start of depression. And also, I would like to draw your attention to relatively fresh data published spring this year. Aerobic physical exercise and exercises with weight could provide positive effect over cognitive disorders and reduces by 62% the risk of depression development in elderly patients. Thank you very much for your attention, and I wish you all the best. I wish you a very good mood and very good cognitive health. Tatiana, thank you very much for your report. Many thanks to speakers that we are sticking to the timing. We have a flood of questions. The topic is very important, so it requires discussion. So hopefully we will enjoy Q&A session at the end. And now let me start with my presentation and speak about meditation in chronic diseases. Meditation. Meditation and chronic diseases. That's quite controversial. Many people believe, well, what is meditation? Probably it's not somehow related to medicine at all, but let's try to dive deep. Is it really so? And why we raise this topic? If you look at the slides, so you will see very clearly that from 2009, we see very strong and very dramatic increase of number of publications. So these are journals with very high index in Scopus and very high impact factor. And for 2023, which just started, the number of publications already increased the rate for 2009 and very soon would increase the amount for 2010. So this is flood of publications due to what? Current approaches now better understood. Let's try to dive deeper. So what do we see here? First of all, we speak about cardiovascular pathologies, and we see very clearly that in these patients, we see a huge peak of cardiovascular diseases that starts approximately from the age of 40. But if we try to understand on the same patient journey before and after 40, let's say, I don't have psychiatry education, but from the point of view of simple psychology, we will see very interesting coincidences. We will see that life of the patient from the youth to the mature has particular peaks. And we know normally younger than 40, the life is very active, and age 40 is a starting point for cardiovascular pathologies. It's starting point for the aging from the position of the WHO, but the same way, age 40 is a peak when you see the onset of the fear of death, even without chronic diseases. When people start losing this continuous competitiveness, they lose competitiveness, and they require evidence of being young, and also plus to that losses of relatives. And now let's try to imagine that It happens with a relatively healthy person, but let's imagine that plus to that, there is onset of cardiovascular pathology, not only cardiovascular, but any chronic pathology. It creates a huge list of challenges. According to very moderate assessment, 27% of the patients with hypertension, they suffer from chronic depression. They're suffering from CHF. So that means in these patients, situation is very serious and pool of these patients is very high. Very frequently, they don't refer for the medical care, but they lose motivation to leave. They lose motivation to be treated. And unfortunately, then problems are just summating relatively negative outcomes. Then clear questions. We were speaking about antidepressants. If we speak about meditation now, but not about antidepressants. So I did not want to provide you this comparison in the clinical trials, such methods like meditation or different practices with antidepressants. I'm focused on the isolated use of meditation. So what do we know? This is hypertension, 8 weeks of comparison, meditation. Systolic and diastolic blood pressure appear to be better than in patients who are not dealing with meditation. The depression rate was reduced. Meditation in the other study led to very significant, it's like with small ACE inhibitors, so reduction of systolic and diastolic blood pressure. And also, let me add here, the other systematic review and meta-analysis, 30 years of evidence-based. And here we see the same in practice based on the consciousness of meditation. So these practices are more effective than the practices of others. So they prove their efficacy in this category of patients. Let's go deeper. Let's speak not only about meditation per se, but also the influence to other parameters beside blood pressure, if we mention hypertension. This is RCT carried out more than 10 years ago. 9 months of follow-up. And this is thickness of intermediate here. And you see clear reduction in the group that had change in the control group in ischemic heart disease. And this is study of 2010. So we see here that there is increased physical exercise and the duration of this exercise. What does it tell us about? It tells us this method provides a very significant effect to the outcome, so the quality of life of the patients. But the question is, and what about CHF in the most severe group? So that's another study, 8 weeks. I will tell you why 8 weeks. It leads to the significant improvement of quality of life and reduction of depression. And moreover, the effect is more than 1 year. We see the second study here, reduction of symptoms. In the other study group studying the meditation, improving the quality of life. So chronic heart failure, the same way could be improved in patients after meditation. But what is interesting for you, this is ICD, implanted cardioverter defibrillations and CHF. And what do we see here? Not only just improvement of survival, but the most interesting here we see also reduction the number of paroxysms in atrial fibrillation. So these are red columns and ventricular tachycardia. So that means the group that having meditation and had fewer arrhythmias. But let's go deeper and ask a question, and how we can explain that. So what does it mean? So why it happens actually? So we're trying to build up particular lines, not only between depressions, chronic stress, that these people survive. And then we see here that meditation could influence cortisol reduction, corticoliberin, and some other hormones. And this is all meditated by hormone of stress plus steroids that automatically leads to the reduced number of heart rate and blood pressure levels. So in fact, so number of studies prove that the patients that have meditation reduce corticoliberin, which is responsible for the increased pressure, increased CHF, and also stimulation of the sympathetic nervous system. So it is very good during stress, but not good when we speak about the chronic activation. The same about vasopressin. And by the way, this is one of the most important components that leads to CKD in patients with chronic stress. So They have the same here. This is increased blood pressure. Now, big question. What is the meditation that we are talking about? In the modern world, the meditation is a big practice. In the Western world, it's everything here. So imagination, and the Red Book was written about it, up to the traditions, Buddhism, for example. And all that in meditation, to motion, meditation for breathing, meditation with and without objects, meditation with visualization, etc., no matter. So all these practices anyway were used in different clinical trials. I do an apology for not very clear slide. This is quite revolutionary data. This is 2023. This is a study that created a fuss in the medical community. Just think it over. The efficacy of meditative practices in patients with pre-diabetes in combination with yoga appear to be comparable in terms of efficacy with reduction of HbA1c with metformin. So that's absolutely the same, absolutely adequate results, the results that force us to think on how similar practices could change the life of chronic patients or patients with chronic depression. You see this data, I am not sticking to that. And there are much deeper studies, let's say meditation for breathing. Well, it's not easy to do according to different practices where the attention is focused on inhale, exhale. But in any case, in this study, patients that reached the results of such practice with such breathing, they reach dramatic reduction of arterial blood pressure figures. And here you can follow one of my phrases, reach the result, reach the effect. That's explaining why 8 weeks. It takes time, even with the lead of instruction. But if patient is ready and wants to do that, then for 8 weeks, then reach dramatic improvement of their somatic pathologies. Many processes, fewer hormone of stress, etc. And then second key question, should we wait for the development of chronic diseases and practice meditation? Are there any studies in the patients? In a young group, yes, there is interesting data. Meditation is self-consciousness, but nevertheless, in the younger groups, also with depression, we have massive studies, and meditation, according to the data of big data proved its efficacy in the treatment of anxieties, negative and positive effects, and also in the treatment of chronic pain syndrome and depression. And this is also practice. They analyzed people who reached resultativeness of the meditative processes and reaching the result. Naturally, there are some other publications on consciousness and understanding the reasons of sufferings, and also there are more difficult meditation on self-compassion. And it's not easy to explain within 15 minutes, but it is the same way an attempt to cure depressive disorders for the younger category of the patients. And summing up, if we try to use meditation to reduce the level of stress as a mechanism of developing of multiple chronic diseases, hypertension, chronic kidney disease, etc. So we will see that practicing meditation regularly, they reach very significant reduction of cortisol, hormone of stress, and they reach a reduction of high sensitive C-reactive protein and many others. What conclusions can be made here? Meditation could worsen the quality of life of the patient with chronic diseases? Yes. Reduces the figures of systolic and diastolic blood pressure? Yes. Reduces the number of arrhythmias? Yes. The answer is yes. But as usual, there is always but. So first of all, qualified instruction, and then we understand the mechanism, this reduction of stress hormone mechanism, and plus to that, adding to the main medical treatment of these diseases. And summing up, what meditation is now? It's not an attempt not to think, it's an attempt to follow your thoughts, your ideas, and then they follow as a flow. So, and there is no fixation to the thought, to the desirable thought, and these thoughts, they not take patient away, because if patient thinks, so we will frequently see that it looks like we are having rest, but in 3 seconds, we think about something very far away that could provoke disorder. So meditation teaches patients not to do that and be where they are. So there is no doubt I can sum up that this is very good additive technique that is having very good evidence-based data from the position of the modern evidence-based medicine. With that, I thank you very much for your attention. And I would ask just a second, and then we go for Q&A. Many questions here. Unfortunately, we will not be able to speak about breakthroughs in the treatment of chronic depressions and anxieties. I hope you understand why we cannot speak about it in the air. Next question to Anastasia. What should be the correct coding of depression? Because they cannot put code F in their disease history. Thank you very much for your question. I think it can be put here, main diagnosis with the patients, and then it could be depressive syndrome, and that's it. And then to give recommendation, because we know some outpatients, they can give consultations with psychotherapists and give referral to the psychiatrist or psychotherapist. So that is, if you don't have this opportunity, and it could be secondological sense or private. So in your medical records, you should reflect it, that you talk to the patient about the need to continue particular intervention, diagnostic intervention specifically. Thank you very much. Next question. Natalia, I think next question to you, because you mentioned token-based treatment. Don't you think that token-based treatment could increase anxiety of the patient, especially in case, and if the same, but this is endogenous and schizophrenic depression? Well, speaking about anxiety, yes, it can increase the anxiety if we are too much fixed on that. You're right. We should explain to the patient that most important is a control. You should make it like a game, very easy one, especially we speak about very severe elderly patients with severe dementia. So it could be sort of a cognitive training for them. And I think this is very good. And this is a way how you provide this. And it depends, because when we launch the element of control, definitely, we can remove it later on, but we repeat it, we can teach the patient, and then for quite a time, I think we should repeat it. Thank you very much. And now several questions about the use of antidepressants, especially in the younger patients. Can we use Becker questionnaire, and can we administer antidepressants that are not in the depression after cardiological event? Yes, we can. Alexander, hopefully you can hear me. Yes, of course, we can. Can you hear me? Yes, we can hear you. Yes, we can use Becker questionnaires and our hospital scale of anxiety and depression, which is hot. And you can effectively use SSRI. Sertraline shows very nice effectiveness after the bypass and stenting, but the dose should be properly titrated. Could it be any drug-drug interaction, or it is less probable? Well, we have to keep it in mind, definitely. But if there is a dose titration and if we do it cautiously, normally risk is minimal. I got it. What should be preferable method, Gestalt psychoanalysis or cognitive behavior treatment? Thank you very much for the question, Alexander. If we select from this, definitely cognitive behavioral treatment, CBT. CBT is a standard for the food disorder. And I'm speaking about obesity and the reason of obesity. And it would be optimal. Each of the method could be done, but that's my selection. Do we use hypnosis in these options? Definitely used. That's one of the methods. It could be effective, very effective. The point here is to find a negative message, which is a trigger to start food behavior. And we go step by step from automatical thoughts to the intermediate and then coming to the negative or skipping all that. We go through with hypnosis, reaching the very deep problem. It's just a tool. It's just a tool. It's not, let's say, wow method, which somehow frequently seen in films. It's a little bit different. That's tools like CBT, but a little bit different. And if doctor is aware and masters that, so that's good. So that's good. That's another question to you. For how long we can preserve the effect from psychotherapeutic interventions in patients with increased BMI? So how frequently do we see that? From the point of working, so there is main work here. By the way, I would make a parallel with dietologists, with dietitians. How reaching the objective from the point of psychotherapy and dietology and normalized weight, we still can periodically support meetings with the patients. Let's say first time after the end of treatment, and 3 months, then in 6 months, then once a year. So I'm speaking about dietology, but from the point of psychotherapy, maybe Anastasia would correct me. As a professional, I don't go to her territory because I'm sure she would be able to provide us very full answer. What should be the deadlines of the meeting? How frequently to see the patients? Well, thank you very much for that. Well, the continuation of psychotherapy anti-relapse approaches, they're quite individual. They're very individual. So it happens that it could be quite short therapy. And if this is feeding disorder, let's say first effect, it's cognitive effective. First 10 sessions, and majority of them are 20-25 sessions if there is no strong comorbidity, because sometimes it could be an individuality disorder. And if it's all treated, all good, maybe long is not needed. When they say goodbye at last session with the client, so they always say, I'm always available, always there. If there is any challenge, you can always come. Sometimes it's short courses or maybe single meetings if needed. So here, our personalities, they're similar but still individual. So it should be more individual approach, and there are no clear protocols. Speaking about anti-relapse treatment. Thank you very much. Very good. Natalia and Tatiana, some questions to you. We're mainly speaking about the elderly patients. Let me sum up a couple of questions and put it like this. By the age of 70, no options, but to be in depressions. And we all need some sort of supportive treatment with antidepressants. And sometimes they position that they do it very frequently abroad. Do you think we should go that way and to say that age of 70 is inevitably depression? Well, probably I will speak like a psychologist or like a doctor. There are different types of being old. And there are people with very positive self-perception, where pension, life continuation, new objectives, new tasks, and they like it, they share experience, and they preserve nicely their psychological status, their wisdom, and their basis for the whole family. But definitely we speak about other type of patients here, and they are more prone to diseases. That's another type of personality. Next question. let me sum up. Where is the threshold here when you identify depressive or anxiety disorder in chronic patients? So where the threshold where we need psychotherapy or maybe psychoanalysis, or maybe we should immediately start with antidepressants, specifically from SSRIs, selective serotonin reuptake inhibitors? Well, I can take the floor if you allow. For that, we have our great guidelines on depressions, where we have very clear descriptions of all that. So if depression is a mild, and it should be diagnosed by psychiatrists. So if it's a mild depression, then it could be alternative, specifically cognitive behavioral treatment, CBT, and it has very good evidence-based data, or it could be start with antidepressants with minimal therapeutical doses. And if needed, there could be dose correction later on, and if there is good effect, we also can assess it and deadlines are given. If this is a moderately or severe form of depression, then pharmacotherapy is a must here, but psychotherapy is also preferable, because even if it's a milder depression, or let's say the patient desires antidepressants plus psychotherapy, it's not contraindicated. So it's always a selection. It's not or, it's not and or. So if it's a moderate or higher, then antidepressants are indicated, and psychotherapy is preferable as an option here. Other types perform their function, anti-relapse function, basic function that gives a resource to manage this depressive condition. Thank you very much. Another question here. Difficult question. This is depressive condition after internal organ transplantation, a combination with antidepressants, possibly with cytostatics. Can we use it in patients with immunosuppression? Can we use antidepressants as well, or should we go to psychotherapy exclusively? Or maybe that's a question about drug-drug interaction. That's an interesting question. In my practice, I used trazodone or triticla. It could be combined with cytostatics. Speaking about SSRIs or others, that's quite challenging. As you are here, in clinical guidelines, this is sertraline and metalopram. Sertraline, yes, that's Zoloft or Serenada, yes, we can use it, but citalopram, not always preferable. It could be anxiety, increased pulse and blood pressure. Then we have to remove serotonin bridge to include other anxiolytics, etc. Natalia, would you agree or disagree? I'm not the medical doctor. I cannot respond to that. I cannot answer that. Okay, we move to the next question. And next question, EMDF method, eye movement. Yes. Could it be used in patients with obesity and overweight? So that's a great method, which is a golden standard for post-traumatic stress disorder in the treatment of obesity. I never saw it in the obesity treatment. I never saw that my patients are using these methods. Maybe I don't have enough experience and the colleagues could add on, but it's a treatment of obesity, which is step away from PTSR, and I don't think they use it. What is more important, cognitive behavior, gestalt, medical treatment, or maybe psychoanalysis? How would you distribute that if you speak about patients with chronic disease? Patients who are overweight, and you partially already answered that, patients with heart failure and geriatric patients, if possible. It's important to understand the life story of the patient, cognitive status, his psychotype, and we select treatment based upon that. Again, restructuring of the personality and whether it is possible. So it's important to work with elderly patients and mainly with behavioral treatments. Yes, elderly with dementia. Yes, that's mainly behavioral one. Anastasia, what would you say from the position of psychiatry? Well, I totally agree with our colleague, because still we need to be based on the status of the patients. Any even brilliant method would ever work if it would be wrongly applied to the wrong disease, to wrong severity. If it's cognitive behavioral treatment, then there it should be particular resource. But if there is no resource, let's say very severe depression, very slow thinking, and patient cannot get up and go and clean the teeth, so that's very simple behavioral technique. So what they need is to start moving, at least with cognitive behavioral therapy, CBT. If it's a cognitive disorder, psychoanalysis would be very difficult here. Gestalt treatment, well, requires memory. You should remember when cognitive symptoms are increasing. Unfortunately, the memory is lost, and also we have to follow the particular function. So for each method of treatment, including psychotherapeutical method, there should be an objective. Which objective is here? And then we select proper method. But now let me put to the position of Sigmund Freud and Carl Jung. So I will tell you, all right, young patients with obesity, hypertensive, other methods, could they be applied, or CBT is answer to everything? Not to everything, but, well, first of all, it depends on the therapist, because let's say in psychoanalysis and Gestalt, a lot depends on the personality of the therapist, because you know perfectly CBT methods, but would not be very empathic person that does not listen and does not hear the clients, not very agile and flexible, and not reaching proper results, the results and objectives which are expected. And here it could be even more experienced, very flexible Gestalt therapists. It could be in the positions due to the personal specificities. So it's all psychotherapy is option to communicate between the therapist and the client. The issue of communication is very important, especially among the elderly. It's cognitive stimulation, and psychoanalysis could be also very good if cognitive function is reduced. Just come and talk and stimulate cognitively. All right, can I add a comment? Yes, please. Yes, please, Natalia. We have a couple of more minutes. Yes, one more minute. Also, if we speak about quite young patients with problems of obesity, we should check whether he or she needs personality restructurization, because psychoanalysis is prone to that. Maybe we can teach him or her with new forms of behavior, and then that would be totally different behavior. Or maybe it should be very deep problem that patient is suffering and overeating it, and then we need very deep and very serious work. Yes, we need to move on. With that, I would like to thank all of you, and I will answer the question about meditation. If you recommend your patients to meditate with the probability of 99.9, they would never do that. 4% follow healthy lifestyle after our recommendations. Meditation would be 0.4 to be honest, although the results are very promising. With that optimistic note, with recommendations, well, why not? Maybe karma is ready. With that, I would like to thank our experts for their fantastic presentations, for your time, for your patience, for the connection, and very popular symposium. Hopefully, it was very useful and interesting for our audience. If you have any other questions on the symposium, please write to us into the chat, question on depression, then we'll put it all together and we'll provide qualified answers in our Telegram channel by the end of the conference. With that, thank you very much for your attention, and we are waiting for new symposia, and we proceed with the conference. Hope seeing you later. Thank you. Stay with us.